My dear students, in this video, I am going to discuss about the different variants of Guillain-Barré syndrome, which are important from critical care perspective. We witness a lot of Guillain-Barré syndrome patients in the ICU, and there are differences which are obviously some of which are obvious in during at the time of presentation, and there are some differences which we need to elucidate during the clinical course of the patient. And these are important from the ICU point of view because the management strategies, the prognosis are slightly different in these variants. Let us start with the first case, a 52-year-old man who is post upper respiratory tract infection presents with 5 days of ascending weakness followed by areflexia. The patient is also tachypneic and the single breath count is 10. The key clinical features are symmetric ascending flaccid paralysis, along with sensory symptoms, which are mild, and also facial and bulbar weakness. And this facial and bulbar weakness is usually present in half of the patients at the time of presentation. And on investigations, the CSF shows albuminocytological dissociation, usually after days 5 to 7. The nerve conduction study shows slowed conduction, prolonged F waves, and conduction block. Now, usually this presentation typifies for AIDP or acute inflammatory demyelinating polyradiculoneuropathy, which is the most common variant that we witness in the ICUs. In the ICU, the relevance that it is the most common variant, particularly in India and Europe, and it has a very high ventilator requirement to the tune of 25 to 30%. That is almost one third to one fourth of the patients would require ventilatory support. And another ICU relevant feature is that these patients can have autonomic instability, which is very common. So the priorities in the ICU would be early intubation if the forced vital capacity is less than 20 mils per kg, if there is bulbar weakness along with tachypnea, and both IVIG or plasma exchange are equally effective. So either can be used depending upon the convenience, cost, logistics, etc. And one has to monitor continuously ECG as well as the blood pressure because there are autonomic instability is common. Coming to the second case, it is a 24-year-old man who had a recent history of diarrhea, shows rapid symmetric weakness with preserved sensation. In the previous case, the sensation was affected, but here it is preserved sensation with absent reflexes. The clinical clues would be pure motor involvement with no sensory loss and often severe weakness at present. The investigation shows on the NCS there is reduced CPAP amplitude with normal sensory studies. And if we can do an antibody profile or if the patient has been advised, there will be anti-GM1 antibodies are the common. Now, this is the second variant, which we commonly call as AMAN or acute motor axonal neuropathy. The relevance it is that it is common in the Asia and it has faster progression with early respiratory failure, and often the patients are younger. So the ICU priorities will differ. The anticipate early ventilation in these patients because it progresses quickly, the motor paralysis. Again, IVIG or plasma exchange is indicated. The recovery may be rapid or prolonged depending upon the axonal loss, that how much axonal loss, which may be variable from patient to patient. Moving on to the third case, a 45-year-old woman with septic syndrome presents with rapid quadriplegia and sensory loss and with early ventilator dependence. The clinical features showing severe motor and sensory deficits, frequent autonomic dysfunction, and investigations showing in the nerve conduction study low CMAP and SNAP amplitudes with poor prognostic indicators. Now, this happens usually in AMSON or acute motor sensory axonal neuropathy, which is again one of the although it is the rare, but it is the most severe variant in the ICU and it carries a high ICU mortality. And even if the patient survives, the patient requires prolonged ventilation among all the variants. So in the ICU, priorities would be early tracheostomy planning in these patients because they would obviously require a very long period of mechanical ventilation. Aggressive prevention of ICU acquired weaknesses because This can superimpose upon the motor paralysis and further prolong the recovery, and prolonged rehab is expected. So patients should be counseled and physiotherapy should be continued aggressively in these patients. The fourth case, let us see a 38-year-old man with diplopia, gait imbalance, along with areflexia, but no limb weakness. Now, clinical triad of ophthalmoplegia, ataxia, and areflexia, and investigations shows anti-GQ1B antibodies if the antibodies are measured. Now, this is very much typical of Miller-Fisher variant, that is the Miller-Fisher syndrome variant of GBS. The ICU relevance is that it is usually benign but can evolve to respiratory failure. So one needs to be cautious in these patients, and it may overlap with classic GBS. It is possible. And the priorities in the ICU would be to monitor closely the respiration and IVIG if progression is there or if overlap features develop. Case 5, we are going to a 60-year-old man who is having dysphagia, neck weakness, and arm weakness with preserved leg strength initially. The clinical features show cranial nerve involvement from 9 to 12. The upper limb weakness is more than the lower limb weakness. Now, this occurs in pharyngeal cervical brachial variant of GBS, which is also called the PCB variant. And it has to be remembered from the ICU relevance is that these patients have high risk of aspiration. So one needs to protect the airways to prevent such aspiration pneumonia. Early ventilator failure may happen despite preserved limb power. So one should not get a false reassurance by looking into the power in the limb that these patients won't have respiratory failure, which would prove wrong. So the early ICU priorities would be early airway protection. We should plan for a PEG or NG feeding planning because of the high aspiration risk, and we should treat them as severe GBS. Coming to case 6, a 48-year-old woman who is a labile blood pressure with recurrent bradytachy episodes with moderate limb weakness, also shows features of cardiac arrhythmias, labile blood pressure, ileus and urinary retention, or manifestations of CIAD, including polyuria, etc. So this happens in GBS with severe autonomic dysfunction. This is also considered another variant. Its ICU relevance is because autonomic dysfunction here is a major cause of mortality. And therefore, the ICU priorities would be to continuously monitor ECG and arterial blood pressure, avoid sudden position changes because that may precipitate autonomic dysfunction or dysautonomia, and treat arrhythmias conservatively. That is, temporary pacing may be needed in these patients also because they're otherwise with arrhythmias, there can be risk of embolism, etc. And it can be fatal in many patients too. So these are the 6 variants which can be seen in the ICUs. And if we are able to distinguish the 6 variants early, then probably the course or the clinical course can be anticipated with much more clarity, and planned the management can be planned more scientifically and become more evidence-based other than treating all the 6 variants in as a single or on a common platform. Now, one important aspect I would like to add in this connection is the single breath count. Many people do this test, and if it is also asked in the exam, but certain finer points should be remembered while understanding single breath count. So it is the maximum number a patient can count aloud in a normal speaking voice after one maximal inspiration without taking another breath. So this should be very important. Then how to perform this single breath count? So again, let the patient be set upright at 45 degrees. Ask the patient to take a deep breath in and then ask them to count aloud at 2 numbers per second. 1, 2, 3, 4, like that. In that, the speed should be like that. That 2 numbers should come in 1 second, and stop when the patient must inhale again. And we record the highest number that the patient has reached. So if the SVC is more than 25 to 30, the vital capacity is usually approximated as more than 60 predicted. So it is safe or low risk. If it is between 15 to 25, this patient's vital capacity is about 30 to 60% predicted. So patient requires close monitoring. If it is less than 15, then it is less than 30% of predicted VC. These patients are at high risk. So one should prepare the airway, or the airway management strategies should be ready. And if it is less than 10, then the predicted VC is severe. So it highlights uh, impending respiratory failure. So the thumb rule is that if the SBC is less than 15, then that means that probably the vital capacity is less than 20 mils per kg. So if you remember this, then it will become easier for us to assess patients with single breath count clinically. Now, one more important score which is often asked in the exam, or which is required for resident students, the Erasmus, the EGRI score, or the Erasmus GBS respiratory insufficiency score. Now that takes into account the days between the onset of weakness and hospital admission, and the score can be 0, 1, and 2 depending upon whether the days are more than 7, between 4 to 7, or less than 4. Also, score can be 0 to 1 based on facial or bulbar weakness at hospital admission. If it is absent, the score is 0. If it is present, the score is 1. And MRC sum score at hospital admission can be, if it is less than 20, the score is 4. Between 51 to 60, the score is 0. And in between, we have 1, 2, 3, 4 at intervals of 10. That is 41 to 50, 31 to 40, and 21 to 30. So this gives a total score of 0 to 7, and an EGRIS of 0 to 2 indicates a low risk of mechanical intervention, that is almost 4%. 3 to 4 indicates an intermediate risk of mechanical intervention to the tune of 24%. And if it is more than 5, then indicates a high risk of mechanical intervention. Now, this is a very important and useful score and has been highlighted in many places as an important part of clinical assessment. Another important thing we need to know is that who should receive IVIG. IVIG is recommended in any one of the following conditions if it is present in during GBS. One, non-ambulatory patients who are unable to walk independently, if there is rapidly progressive weakness, if there is respiratory involvement with a single breath count of less than 15 and a forced vital capacity of less than 20 mils per kg, in the presence of bulbar weakness, and in the presence of severe autonomic dysfunction. So what should be the time window? Best if it is started within 2 weeks of the symptom onset, but it can be considered up to 4 weeks in severe patients. One should not wait for CSF or NAR conduction study confirmation if the clinical suspicion is high, because in that case we unnecessarily lose a lot of time. Now, this is one, there has been a lot of studies on which compared plasma exchange with IVIG in GBS. And this is the one which is late. This is a systematic review and meta-analysis, the latest one, which has been published in 2023. And although more than 532 articles are there, this has taken the major 20 studies. And they have suggested that both IVIG and PE have similar curative effects, relapse rates, reductions in hospitalization and ventilation length, and potential risk for complications. However, the analysis suggests that IVIG is easier to use. So based on these results, it is recommended that IVIG be preferred for treating patients with severe symptoms of GBS. So one should know the standard IVIG regime. The total dose is 2 grams per kg given as 0.4 grams per kg per day for 5 days, which is the most common. Or in select patients, it can be given 1 gram per kg per day for 2 days. The weight, we should use actual body weight, and only in morbid obesity, one should consider adjusted body weight. During IVIG infusion, it is important to monitor for hypotension or hypertension, headache, fever, chills, fluid overload, especially if the patient is on ventilator, arrhythmias if the patient is having autonomic dysfunction, because that can get precipitated during IVIG. The infusion tips should be that we should start slowly and escalate gradually, and use sucrose-free preparations in the ICU because they will tend to cross-react and they will reduce its efficacy, and always avoid any volume overload. Always remember that combining IVIG and plasma exchange offers no added benefit and it is not recommended. So if one of the therapies have been used, the other therapy should not be superimposed. Now, this is something which one should go through. It is a very nice article available freely uh, in the net. It is a review which has been published in the Nature Reviews in 2019, the diagnosis and management of GBS in 10 steps. And from here, the acute care part has been highlighted very nicely. That is from where I have picked it up, that which is important for all the practitioners in critical care, that when to admit to the ICU, that is when the patient is having one or more among these four: rapid progression of weakness, severe autonomic or swallowing dysfunction, evolving respiratory distress, or an egress of more than four. When to start treatment, again one or more: inability to walk more than 10 meters independently, rapid progression of weakness, severe autonomic or swallowing dysfunction, and respiratory insufficiency. Treatment options, as I told, either intravenous IVIG, that is 0.4 grams per kg daily for 5 days, or plasma exchange 200 to 250 ml per kg for 5 sessions. Monitoring, regular assessment for muscle strength, respiratory function, swallowing function, and autonomic function in the form of blood pressure, heart rate and rhythm, and bladder and bowel control. We have to know the early complications, which includes choking, cardiac arrhythmias, infections, DVT, pain, delirium, depression, urinary retention, constipation, corneal ulceration, dietary deficiency, hyponatremia, pressure ulcers, compression neuropathy, limb contracture. So any of those, we can have a particular preponderance in a specific patient, depending upon the presence of the comorbid factors. And clinical progression, either there can be treatment related fluctuation, so we can repeat the same treatment although the evidence is not so strong, and no initial response and incomplete recovery, then there is no evidence for repeating the treatment. So therefore we have to be very careful in these aspects of acute care. So my take home message would be that when the variant is in AIDP, the key ICU risk factor is both autonomic and respiratory. So here commonly ventilation is required, but the prognosis is good. In AMAN, the key ICU risk factor is rapid respiratory failure because of motor paralysis. Here the ventilation requirement is early, the prognosis is variable. In AMSAN, here the key ICU risk factor is severe as well as it is prolonged ICU stay. The risk of ventilation is very high and the prognosis is poor. In Miller-Fisher variant, it is the key ICU. They are usually mild. Ventilation is rarely required. Prognosis is excellent. In pharyngeal cervical bulbar, here the key ICU risk factor is of aspiration. So early intubation is required. Risk of ventilation is high, but the prognosis is good. In autonomic dominant arrhythmias, there will be this because of autonomic dysfunction, there are blood pressure swings. Here also the requirement of ventilation is variable depending from patient to patient, and the prognosis also depends upon the nature of autonomic complications. Thank you.